Hello, everyone. If you're in your final year of medical studies, you are about to see a lot of abdominal wall hernias on your surgical rotation. So this explainer is designed to give you the core knowledge that you will need, starting right from the very basics.
Okay, let's dive right in. You see, before we can even begin to talk about fixing a hernia, we must first know where they happen. Think of this slide as a map of the battlefield. The areas you see marked in red are the common culprits: your inguinal, your femoral, umbilical hernias. The black areas are the rare ones. But all of them, every single one, represents an inherent weak point in the abdominal wall, a place where a breach is just more likely to occur. So we're going to build our understanding logically, step by step. First, we will look at the design of the abdominal wall itself. Then, we'll define exactly what a hernia is and what causes it. We'll move on to its complexity, then to clinical diagnosis at the bedside, and finally, we'll cover the core principles of how we manage these surgically. All right, section 1. Before we can understand the breach, we have to understand the container. So let's take a closer look at the design of the abdominal wall. You know, the abdominal wall is really a masterpiece of biological engineering. It has to be strong enough to protect all our vital organs, but at the same time, it must be flexible. And it's this very need for elasticity to allow us to move, to breathe, to accommodate changes like pregnancy that inherently creates these areas of potential weakness. Now have a look at this cross-section. What's absolutely fascinating is the design. Laterally, on the sides, you can see these 3 distinct layers of muscle, with their fibers running in different directions. It creates a very strong, cross-hatched wall. But right in the center, you have the linea alba, which is just a single sheet of fascia. Now, it is strong, yes, but it is also a natural point of weakness when you compare it to the muscular flanks. And this image brilliantly illustrates a crucial clinical distinction you must make. What you are looking at here is called a divarication of the recti. This is not a true hernia. It is simply a stretching, a widening of that central linea alba. There is no defect, you see, no actual tear in the fascia for the bowel to protrude through. Differentiating this from a true midline hernia is a key skill you must possess.
So if that last slide was not a hernia, then what is? Well, that brings us perfectly to our second section, defining the breach and understanding what causes it.
So the crucial point is this. We have a defect, an actual opening in that container wall, and something from the inside, like the bowel or some omentum, is pushing its way out through that defect. It is a very simple concept, really, but one with profound and sometimes dangerous consequences. So what causes that defect in the first place? It is rarely just about lifting something heavy one time. As you can see from this list, it's often a multifactorial problem. You might have an underlying anatomical weakness from birth, or a developmental issue, or even a genetic weakness in the very collagen that makes up your tissues. That episode of heavy lifting is often just the final straw that breaks the camel's back. Now that we know what a hernia is, we must learn to classify it. And I assure you, this is not just an academic exercise. This classification directly tells us how urgent the situation is and what the immediate risk to your patient is. First up, we have what is called a reducible hernia. This is the simplest state. It means the contents of the hernia sac that can be easily pushed back into the abdomen. Your patient might even tell you, "Doctor, it's a lump that goes away when I lie down." At this stage, it's not an emergency. Next, the situation can escalate to irreducible. This is a significant step up in risk. Now, the contents are trapped. They can't be pushed back in. This might be due to swelling or adhesions from previous surgeries or simply a very narrow opening. And from this moment on, well, the clock starts ticking. Now we move to incarcerated. The contents are not just stuck. The pressure inside that hernia sac is rising. Imagine a traffic jam. The low-pressure venous blood can't get out. This causes the trapped tissue to become congested and swollen, which makes the problem even worse. This is a dangerous situation, and we are getting very close to the point of no return. And this is the final, most feared complication, strangulation. The pressure is now so high that it has completely cut off the high-pressure arterial blood supply. And if there's no blood getting in, the tissue starts to die. That is ischemia. This is a code red surgical emergency. Every single minute you wait, more tissue is dying and your patient's life is in very real jeopardy. And this is the grim result. This image shows a gangrenous segment of bowel. Just notice how dark and lifeless that tissue is. That is necrosis. This particular case was a Richter's hernia. which is a very tricky type where only one side of the bowel wall gets trapped in the defect. It is a very stark illustration of why strangulation is so life-threatening.
Let us now take all this theoretical knowledge and apply it where it matters most, at the patient's bedside. How do you actually diagnose a hernia in the clinic or on the ward?
I want you to remember this clinical pearl from Bailey and Love. We are often taught that a cough impulse is the defining sign of a hernia, but it is just not that simple. An irreducible hernia with a very tight neck might have no impulse at all, and other conditions, like a saphenous can have one. Diagnosis requires a thoughtful combination of signs, not just relying on a single finding.
So, when you are with a patient, you must be systematic. Go through your checklist every single time. Can you reduce it? Is there a cough impulse? Is it tender when you touch it? Check the skin for any redness. That's a key sign of strangulation. Always compare to the other side. Look for old surgical scars. And a crucial point, for any growing swelling in a male patient, you must always examine the scrotum.
And so we arrive at the final part of our discussion today, the principles of surgical management. We have understood the problem. Now let us understand the solution. You see, the fundamental surgical challenge is not just to close the defect. If we were to simply suture the edges together under tension, the rate of recurrence would be unacceptably high. The real question is, how do we reinforce the abdominal wall to create a durable, tension-free repair? Well, the answer in modern surgery is prosthetic mesh. This mesh serves one of three key functions. It can bridge a defect that's just too large to close. It can be used as a plug in very small defects, or, and this is the most common use, it is used to augment and reinforce a primary suture repair, taking all the tension off that suture line. And here is what that looks like in practice. These are two laparoscopic views of synthetic mesh being placed inside the abdomen. Now, the goal of these materials is to be inert, to not cause a reaction, but to act as a kind of scaffold. Over time, the body's own tissue will grow into the pores of the mesh, creating a permanently reinforced, strong repair.
But you see, simply using mesh is not enough. Its position is absolutely critical. We can place it on top of the muscles as an onlay or deep to them as a sublay. Now, deeper placement has a significant mechanical advantage. And why is that? It's because the body's own intra-abdominal pressure, the very force that caused the hernia in the first place, now works for us. It pushes the mesh against the abdominal wall, holding it firmly in place. It's really quite elegant. I will leave you with this final thought. A routine hernia repair, on the surface, can feel like a simple operation. But the complications, things like recurrence, infection, and particularly chronic pain, which can affect up to 20% of patients, they are not simple at all. So as you embark on your careers, I want you to consider this question. Where does your responsibility truly end? Is it when you place the last skin suture, or is it with the patient's long-term well-being and their quality of life? Think about it.